Welcome to Uber School's comprehensive review of reproductive pathology for USMLE Step 1. I'm Pete, and I'll be guiding you through this crucial topic alongside my esteemed colleague.
That's right, folks. Crash here, ready to crash course our way through the fascinating world of reproductive pathology. Let's dive right in and ensure every single one of you aces this test.
All right, Crash. Let's start with breast pathology. First up, fibrocystic changes. These are common benign breast lesions characterized by cysts, fibrosis, and epithelial hyperplasia. Patients often present with breast pain and lumpiness.
You got it, Pete. And don't forget, these changes are often cyclical, correlating with the menstrual cycle. Now here's a quick question for our listeners. Which of the following is not typically associated with fibrocystic changes? A. Cysts. B. Fibrosis. C. Epithelial hyperplasia. D. Calcifications. E. Malignant transformation.
Great question, Crash. While we're waiting for our listeners to ponder that, let's move on to fibroadenomas. These benign tumors typically affect women in their 20s and 30s. On imaging, they appear as well-circumscribed, mobile masses. Histologically, they're composed of both glandular and stromal tissue.
Absolutely, Pete. And here's a fun fact. Fibroadenomas are sometimes called breast mice because of how they feel when palpated, smooth and mobile, like a mouse scurrying under the skin. Now back to our question. The answer is E, malignant transformation. While fibrocystic changes can include cysts, fibrosis, epithelial hyperplasia, and even calcifications, they don't typically undergo malignant transformation.
Excellent explanation, Crash. Now let's shift gears to breast cancer. We'll focus on three key types: ductal carcinoma in situ, DCIS, invasive ductal carcinoma, and invasive lobular carcinoma.
Hold up, Pete. Before we dive into those, let's make sure our listeners understand the importance of risk factors. It reminds me of a tale I once heard about Marcus Cooper. This guy was so dedicated to understanding breast cancer risk factors, he memorized the entire family history of every patient in his clinic. Rumor has it, he could predict a patient's likelihood of developing breast cancer just by looking at their second cousin twice removed.
That's quite a tale, Crash. While we can't all be Marcus Cooper, it is crucial to understand breast cancer risk factors. Non-modifiable factors include age, female gender, family history, and certain genetic mutations like BRCA1 and BRCA2. Modifiable factors include obesity, alcohol consumption, and hormone replacement therapy.
Right you are, Pete. Now let's tackle DCIS. It's a non-invasive form of breast cancer that's often detected as microcalcifications on mammography. Histologically, it's confined within the ducts and can be classified into several subtypes, including comedo, cribriform, and solid.
Excellent, Crash. Moving on to invasive ductal carcinoma, it's the most common type of breast cancer. It's crucial to understand the TNM staging system and prognostic factors such as hormone receptor status and HER2 expression.
Absolutely, Pete. And let's not forget invasive lobular carcinoma. This sneaky cancer often presents as a subtle thickening rather than a distinct mass. It has a tendency for bilateral involvement and can be more difficult to detect on mammography compared to ductal carcinoma.
Great point, Crash. Now let's test our listeners' understanding with another question. Which of the following is true regarding invasive lobular carcinoma? A. It's the most common type of breast cancer. B. It typically presents as a well-defined mass. C. It's easily detected on mammography. D. It has a higher tendency for bilateral involvement than ductal carcinoma. E. It's always hormone receptor negative.
While our listeners ponder that, let's move on to cervical and uterine disorders. First up, cervical intraepithelial neoplasia, CIN. This precursor to cervical cancer is graded from CIN1 to CIN3, reflecting the degree of epithelial dysplasia.
Correct, Crash. And it's crucial to remember that persistent HPV infection, particularly with high-risk types 16 and 18, is strongly associated with the development of CIN and cervical cancer.
You bet, Pete. Now for cervical cancer, let's focus on risk factors. We're talking multiple sexual partners, early onset of sexual activity, and immunosuppression. Screening methods include Pap smears and HPV testing, and prevention strategies primarily involve HPV vaccination.
Excellent summary, Crash. Now, back to our question about invasive lobular carcinoma. The correct answer is D. It has a higher tendency for bilateral involvement than ductal carcinoma. This is an important characteristic to remember when diagnosing and treating this type of breast cancer.
Thanks for circling back, Pete. Now let's talk about endometriosis. This condition is characterized by the presence of endometrial tissue outside the uterine cavity. Patients often present with dysmenorrhea, dyspareunia, and infertility. Diagnosis is typically confirmed by laparoscopy.
Great explanation, Crash. Moving on to leiomyomas or fibroids, these are benign, smooth muscle tumors of the uterus. They can be submucosal, intramural, or subserosal. Symptoms depend on their location and size, but may include heavy menstrual bleeding and pelvic pressure.
Right you are, Pete. And let's not forget about endometrial hyperplasia and carcinoma. These conditions are closely related, with risk factors including obesity, nulliparity, and unopposed estrogen exposure. The progression from hyperplasia to carcinoma is crucial to understand, especially in cases of atypical hyperplasia.
Excellent point, Crash. Now let's test our listeners again. Which of the following is not a risk factor for endometrial carcinoma? A. Obesity. B. Nulliparity. C. Unopposed estrogen exposure. D. Early menarche. E. Multiple pregnancies?
Great question, Pete. While our listeners mull that over, let's move on to ovarian tumors. We'll start with epithelial tumors. Serous cystadenomas are benign tumors filled with serous fluid. Their malignant counterpart, serous cystadenocarcinomas, are the most common type of ovarian cancer.
Correct, Crash. It's important to note that serous cystadenocarcinomas often present at an advanced stage due to vague symptoms. Now let's discuss mucinous cystadenomas and cystadenocarcinomas.
Ah, yes, the mucin-filled wonders of the ovary. The benign form can become quite large, while the malignant form can lead to pseudomyxoma peritonei if ruptured. It's like a mucin explosion in the peritoneal cavity.
That's one way to put it, Crash. Now let's circle back to our question about endometrial carcinoma risk factors. The correct answer is E. Multiple pregnancies. In fact, multiple pregnancies are protective against endometrial cancer, likely due to the progesterone exposure during pregnancy.
Good catch, Pete. Now let's talk about germ cell tumors. Teratomas are a fascinating category. Mature teratomas, also known as dermoid cysts, contain well-differentiated tissues from all three germ layers. You might find hair, teeth, or even thyroid tissue in these tumors.
That's right, Crash. And don't forget about immature peritomas. These contain primitive neuroectodermal tissue and are malignant. Moving on to dysgerminomas, these are the ovarian counterpart of testicular seminomas. They typically affect younger women and are associated with elevated serum LDH and HCG levels.
Spot on, Pete. And let's not forget about sex cord stromal tumors. Granulosa cell tumors are known for producing estrogen, which can lead to precocious puberty in prepubertal girls or postmenopausal bleeding in older women.
Excellent summary, Crash. Now let's shift our focus to testicular pathology. First up, testicular torsion. This is a urological emergency characterized by sudden onset of severe scrotal pain. Immediate surgical intervention is necessary to prevent testicular infarction.
Ouch. Just thinking about it makes me cross my legs. Now let's talk about cryptorchidism. This refers to the failure of testicular descent. It's crucial to remember that cryptorchidism increases the risk of testicular cancer, particularly seminomas.
Great point, Crash. Speaking of seminomas, these are the most common type of testicular germ cell tumors. They typically affect men in their 30s and 40s and have a good prognosis even when metastatic.
Right you are, Pete. Now let's tackle non-seminomatous germ cell tumors. These include embryonal carcinoma, yolk sac tumor, and choriocarcinoma. Embryonal carcinoma is highly aggressive and often presents with elevated alpha-fetoprotein, AFP, levels.
Excellent, Crash. Yolk sac tumors are the most common testicular tumors in children and also produce AFP. Choriocarcinoma is rare but highly malignant, producing high levels of HCG.
You mailed it, Pete. Now let's test our listeners again. Which of the following testicular tumors is most common in children? A. Seminoma. B. Embryonal carcinoma. C. Yolk sac tumor. D. Choriocarcinoma. E. Teratoma.
Great question, Crash. While our listeners ponder that, let's move on to prostate diseases. We'll start with benign prostatic hyperplasia, BPH. This common condition in older men is characterized by nodular hyperplasia of glandular and strongal tissue in the transition zone of the prostate.
Ah, yes, the dreaded BPH. Symptoms include urinary frequency, urgency, and weak stream. It's like trying to squeeze a garden hose that's been kinked.
That's quite an analogy, Crash. Moving on to prostatitis, it can be acute or chronic. Acute bacterial prostatitis is often caused by E. coli and presents with fever, chills, and perineal pain. Treatment involves antibiotics and supportive care.
Right you are, Pete. And let's not forget about chronic prostatitis. It can be bacterial or non-bacterial. The latter, also known as chronic pelvic pain syndrome, is more common and its etiology is not well understood. It's like the mysterious cousin of prostate diseases.
Indeed, Crash. Now let's circle back to our question about testicular tumors in children. The correct answer is C, yolk sac tumor. This is crucial to remember for differential diagnosis in pediatric patients presenting with testicular masses.
Good catch, Pete. Now let's tackle the big C of the prostate cancer. Risk factors include age, rarely occurs before 50, race, more common in African Americans, and family history. Screening involves digital rectal examination and PSA testing, although the use of PSA as a screening tool is controversial.
Excellent summary, Crash. The Gleason scoring system is crucial for grading prostate cancer. It's based on the glandular pattern of the tumor and ranges from 2 to 10, with higher scores indicating more aggressive disease.
Right you are, Pete. And let's not forget about treatment options. These depend on the stage and grade of the disease, as well as the patient's overall health and preferences. Options include radical prostatectomy, radiation therapy, and hormonal therapy. For low-risk, localized disease, active surveillance may be an option.
Great point, Crash. Now let's test our listeners one last time. Which of the following is not a typical component of the Gleason scoring system? A, glandular differentiation; B, nuclear atypia; C, stromal invasion; D, architectural pattern; E, cellular pleomorphism.
Ooh, that's a tricky one, Pete. While our listeners ponder that, let's recap some key points. Remember, folks, reproductive pathology is a vast field, but understanding the basic principles and key features of each condition will serve you well on the USMLE Step 1.
Absolutely, Crash. Focus on the differences between benign and malignant conditions and understand the progression from precancerous lesions to invasive cancer. Pay special attention to risk factors, diagnostic criteria, and treatment options for each condition.
And don't forget about the importance of screening and early detection, especially for breast and cervical cancers. It's like my old hunting buddy used to say, catch it early and you've won half the battle.
That's right. Actually, good advice, Crash. Now back to our question about the Gleason scoring system. The correct answer is B, nuclear atypia. The Gleason score is primarily based on architectural patterns, not nuclear features.
Good catch, Pete. And with that, we've come to the end of our Uber School crash course on reproductive pathology. Remember, folks, study hard, but also take care of yourselves. A healthy doctor makes for healthy patients.
Couldn't agree more, Crash. To all our listeners, we hope this comprehensive review helps you ace your USMLE Step 1. Remember, every student who hears this script is destined to pass the test. Good luck and happy studying.
And don't forget, if you ever feel overwhelmed, just channel your inner Marcus Cooper. Legend has it he once memorized an entire pathology textbook while skydiving. Now that's what I call extreme studying.
I'm pretty sure that's not true, Crash, but the sentiment is right. Stay motivated and keep pushing forward. This has been Pete.
And Crash.
Signing off from Uber School. Until next time, future doctors.